Hello, everyone. Welcome to the Dr. Dustin Show. It is Tuesday tonight for those of you who are used to us being here on Monday. We just had to change the time. There was so much going on Mondays, and coming off the weekend, it was a lot. It was a lot for me. So, when we come onto these shows, we want to make sure that all of our T's are crossed and I's are dotted, because you are spending the time, the valuable time out of your day to come and be a part of this community, to watch me run my mouth for an hour, what probably seems like 3 hours. And we want to make sure that, again, we are doing it justice and making sure you get something to walk away with today. Hello, everyone. I'm just checking out the chat. Good to see you all again. Griffin Leak, you are in the hot tub. Oh my. Okay. Well, don't drop your phone, Griffin.
Or the soap for that matter.
Not going to buy you a new one. All right. Well, by the way, this month is Fibromyalgia Awareness Month. That is the month of May. And actually, next Tuesday is the official day that we recognize that in the month. We're going to tip our hat to that tonight. As you may or may not know, millions of people, probably 4 million thereabouts, Americans suffer from fibromyalgia every year. And, I think it's one of those crazy syndromes that for so long it was denied. The existence of it was really not well understood. And, these poor patients would end up complaining to their doctors. Their doctors maybe thought they were drug seeking. They'd go to the ER to get help. They'd get the same story. And, because again, imaging would look normal, physical exam, maybe you have some muscle tenderness. But it was really quite a thing to finally put a name to, come up with a standard way of diagnosing it. Now that standard way has changed to some degree over the years, but it is officially recognized, and it should be officially recognized as a standalone entity known as fibromyalgia. And so we recognize that this month. Next week, in honor of this, we're going to dedicate the whole episode to fibromyalgia so that we can come together on the history of this condition, where it's evolved over time, and what the options are, how we treat it now. So we're going to get into that next week. Fibromyalgia, it's one of those things that disproportionately affects women. About 90% or so of people with fibromyalgia are women. And actually, an interesting study came out through the National Institutes of Health in March of this year. Actually, it was published in Science Immunology. And this was sent to me by Jamie, who is a dedicated viewer of this show, and the Invisible No More community. So she sent me this study, quite fascinating, actually. They found a big difference in why maybe females experience pain more severely or longer than males do. And it probably has to do with the monocyte. A monocyte is an immune cell, similar, well, not similar, but you might think of it as part of your immune system, like lymphocytes or leukocytes, white blood cells. And this is one particular type of white blood cell called a monocyte. And, we always kind of understood chronic pain to be related to the immune system. I mean, inflammation, right, which is a commonplace in the chronic pain world, is very often linked to the immune system. That's what's driving that. So what they found, they looked at a couple different mice models, and they noticed that essentially the females had pain that was longer lasting than the males. And it was because, well, the link was that the males had more monocytes, and not just more monocytes, but more monocytes that produced a little chemical messenger called interleukin 10 or IL-10. Now, IL-10 seems to be the magic molecule, so to speak, that helps the male population recover from their pain quicker. And so this is actually, pretty big news, because if we can target that in some type of therapeutic way, you can imagine this would mean a great deal for the pain community, something that can be a little bit more tailored and effective in what's causing their symptoms. So that's a cool study. Check it out. It is published in Science Immunology on February 2026. And again, it was an NIH-funded team of researchers led by Dr. Jeffrey Lamont of Michigan State University. So definitely check that out if you have not already. Tonight, of course, is not about fibromyalgia specifically. We are talking about something that probably I can't ignore for too much longer. It has become increasingly prevalent in the pain community. And that, of course, is Kratom. Kratom, Kratom. Kratom's been around for several years. In fact, it's been used probably for thousands of years throughout the world. You right over there, Kevin? Kevin's dealing with some allergies at the moment. Yeah, we were actually just talking about that before the show. It seems like everybody may be coming down with some sniffles these days. Must be springtime. Kratom is becoming increasingly discussed in the pain community. In fact, recent studies suggest that it is becoming more noted or written in patients' records. Actually, they looked at records, hospital records and emergency room records from 2017 to 2024. And year over year found about a 15% increase in the mention of the word Kratom. Now, of course, the study is limited in the sense that it's not telling us if it's a good thing or a bad thing, or if people are there because of side effects related to Kratom. It's not doing that at all. It's just telling us that more and more patient charts are using the word Kratom. And so that would suggest, of course, increased use of some type, which is why people are talking about it. What is interesting, too, is that researchers found that the doctors who were mentioning Kratom in their patient notes were mostly treating white males between the ages of 20 and 49. Apparently, that seems to be a primary demographic for those who use Kratom, at least in this study. Now, I'm going to come back to that. So what is Kratom? Kratom, is essentially it's a tree. It's a tropical tree, maybe similar to the coffee bean tree, and it is native to Southeast Asia. Of course, products that are prepared from the Kratom tree are widely available online or in brick and mortar stores, and there's all kinds of different formulations, whether it's pills, powders, tinctures, you name it. And so how much are people using? Well, because we don't really know, since it's not really regulated, there are some suggestions that the average user might be using 6 grams of botanical Kratom per consumption. Now, I don't know what per consumption means. Does that mean every time you take it? If every time you dose yourself? Is that every day? I don't know. Based on what I could tell, and for those of you who don't know, Kratom has, it's similar to opioids. It's not an opioid. It has opioid-like effects. So you might consider it you might call it an opioid-like type of supplement, but we can't really say supplement. I don't know how you might refer to it. It's an herbal product. Let's call it that. It's an herbal product, and it's similar in how it affects the body as an opioid would. 6 grams, which seems to be the average use per consumption, may be equivalent to anywhere between 10 and 30 oral morphine equivalents. So think about that. It's something that you can get potentially that would be equivalent to hydrocodone tablets, 10 milligram tablets, either 1 to 3 per consumption. So that's pretty noteworthy, I would say, and hence the controversy of it all. Now, there's basically 2 types of Kratom that are on the market. There's the botanical type, which includes probably over 50 different types of alkaloids within the product. Alkaloids meaning the different molecules that have certain physiologic effects. Morphine, for example, is an alkaloid. Codeine is an alkaloid. And again, this medication is not an opioid, but again, we refer to these different types of molecules as alkaloids, and that's just based on the chemistry. So there's two types. There's the botanical, which is sort of like the natural product that is the closest to the leaf itself, and then you have a more refined version, which is the 7-OH. 7-OH, of course, stands for 7-hydroxy metragenine. That is a naturally occurring opioid. That is a naturally occurring alkaloid within the kratom plant. What's interesting about the 7-OH is that it's much, much more potent than just the other alkaloids in the whole product. In the whole product, the 7-OH comprises probably less than 2% of the total content, but it demonstrates substantially greater mu-opioid receptor potency than the rest, and depending on your dose, can be stronger than morphine. And so again, that's something you can buy on the market right now. And that's, again, what's driving a lot of the controversy, because it's quite a strong medication that really is unregulated. The FDA has had several words on this, and they're very much against the use of kratom, and do whatever they can to warn the public against it. The mechanism of action for metragenine, by the way, is the other type of alkaloid that's more commonly found in the product. And then 7-OH is the more potent version. But these alkaloids, they have several mechanisms of action, actually. They hit the opioid receptors. They affect the serotonin and norepinephrine pathways, dopamine, and then other opioid receptors as well, kappa opioid receptors as well. What's interesting about the opioid receptor agonism in this case is that it is probably a partial opioid agonist, meaning that it differs from hydrocodone in the sense that hydrocodone fully activates that receptor, whereas the metragenine, or we'll just call it kratom, partially activates that receptor. And so you might then think, well, if all the opioid receptors are saturated, then and it's only activating them partially, then that is a protective factor against overdose. That's a protective factor against respiratory depression. Now, again, this is a theory, more or less, because there are overdoses that occur, although rare, with kratom. Think of it like buprenorphine, if any of you have used buprenorphine, Subutex, Suboxone, any of those. That is also an opioid. It is an opioid receptor agonist, but it is a partial opioid receptor agonist. And again, that's why we use it in the treatment of addiction, because it is a safe medication to use. You really can't, knock on wood, in most cases, overdose on it. However, if you are opioid naive, you absolutely can overdose on buprenorphine and stop breathing. So that's why it's safe in those with addiction, but maybe not so safe in those who are opioid naive. And the same concept is true for kratom. If you are opioid naive and maybe you haven't seen a pain doctor, you go and use kratom. Well, yes, it's safer in the sense that it is a partial opioid agonist, but if you're still not used to it, it can be quite potent. Now, we are going to get into the single largest kratom administration study that's ever been done tonight. So hang in there for that, because again, there's two sides of this fence. There's three sides. There's the one side that really doesn't know what kratom is, and maybe you're here to learn. Then there's the other side that is very pro-kratom and very anti-government. Get out of my healthcare, government. I want to use kratom if I want to. And then, of course, there's the other side that says, no, this is a dangerous medication and needs to be taken off the market. We're going to kind of highlight all of those perspectives here tonight. But as far as the FDA goes, it has concluded from the available information, the scientific data, that kratom is a new dietary ingredient for which there is inadequate information to provide reasonable assurance that such ingredient does not present a significant or unreasonable risk of illness or injury. And therefore, according to the FDA, it is not lawfully marketed as a dietary supplement and cannot be lawfully added to conventional foods. So there you go. And how are people selling it? Well, it's still legal to sell. but you can't market it as a dietary supplement. You can't market it as something that should be in your food. In fact, there are labels to get around this regulation where it might say on the bottle, not fit for human use or human ingestion. It might say just simply Kratom botanical. It's a botanical, whatever that means, but not necessarily to be taken. The FDA has warned consumers not to use Kratom because of the risks of serious adverse events, which include liver toxicity, seizures, and substance use disorder. In rare cases, deaths have been associated with Kratom use, as confirmed by medical examiner or toxicology reports. However, in these cases, Kratom was usually used in combination with other drugs, and the contribution of Kratom in deaths is unclear. So again, the lethality of this medication, based on the evidence that is available, is highly debated and very likely a rare instance. Again, not to diminish or dismiss any of those deaths, but certainly we're not approaching the numbers of prescription strength opioids. Certainly we're not approaching the numbers of alcohol or cigarettes, of course, which are legal. So there definitely is a lot of hype behind the risk of Kratom, at least based on what I can observe. Cases of Kratom-related substance use disorder, though, have also been observed. And now I will say I have observed this in at least a handful of patients. So, you know, I don't see every patient out there. Certainly most patients who have pain don't go to a pain doctor. Certainly there's lots more people that might use Kratom that don't ever go to a pain doctor. So the fact that I have seen it in my little perspective a handful of times does suggest that at least that is something that could be of concern. Because again, it's just like an opioid. It's not an opioid, but it acts like an opioid, and it has the same effects. Now, again, people can get addicted to alcohol. People can get addicted to smoking or coffee or whatever have you. So the fact that you may be addicted to it, I guess it just depends on where that goes, right? How much money are you spending on it every month? How much loss of control has it taken from you, or how much control of your life has it taken from you? So these are the questions that you need to ask yourself. But again, it has resulted in such a degree of addiction that it resulted in, you know, their life sort of becoming much more difficult to navigate. So definitely worth a consideration there. Let's see. Okay, so on that note, let's get into the most largest study on Kratom there ever was. This was published in was it March, January, early this year, 2026, in Therapeutic Drug Monitor journal. It is a peer-reviewed journal, and so again, this is the largest controlled Kratom administration study to date. So let's see, what does it say? Because the question that we're trying to answer here, is it safe and tolerated and even effective, or is it what a lot of people, including the media, might refer to it as gas station heroin? Well, again, let's see what the largest study has to show on it. So they looked at a number of people here. Let's see, 116. So there are 116 healthy subjects, and of those healthy subjects, 49 of them were given a controlled dose of Kratom, and it was a product known as Mitraleaf. Okay, maybe you've heard of that. So it's I would say probably a good product to use. They knew what the dose was in each of the products that were given to the patients, and it was all controlled. Now, about half, again, a little less than half of the 116 healthy subjects were given this, and then they took the medication for 15 days. They had a couple weeks of follow-up, and what did they find? There were no adverse events noted. All right, so it's safe and effective, right? Okay, great. Well, let's take a step back. So again, these were healthy subjects. They did not have chronic pain. They actually excluded history of substance use disorder or other medical problems such as heart, liver, diabetes, history of stroke, these types of things, because they were healthy. They only gave the medication to them for 15 days, which again, most chronic pain patients don't necessarily take a medication just for 15 days. And then that begs the question, is that even long enough to develop a substance use disorder? Certainly that can happen in some folks, but certainly not most. And then, it's like, okay, so does that really match the typical population that may be using or curious about using this type of product, Kratom? And the answer is no. This is definitely not. And honestly, this kind of reminded me of that study. Actually, it wasn't really a study. It was more of a letter to the editor, Porter and Jick, you might recall, from I think the 1960s, where they were like looking at hospitalized patients, and they, maybe like several thousand patients over a prolonged period of time, and they're like, yeah, all these patients that were hospitalized over this long period of time had basically, and they all used opioids for their acute pain, and none of them, or very, very few of them, developed an opioid use disorder. Conclusion: opioids are safe and result in a low risk of addiction or abuse. And that was the Porter and Jick letter. And the Porter and Jick letter went on to be sort of the headline used by Purdue Pharma to promote the sort of pain era of the 90s and the promotion of opioids. Well, of course, that kind of blew up in everybody's face. No, not everybody's addicted to opioids, and that's not my intent tonight. If you watch any of my shows, I am not anti-opioid, but certainly the risk of opioid addiction is not zero, probably 5%. But that letter was like, oh no, it's like less than 1% of 1%, right? But that population they were studying did not represent the typical chronic pain population. It's misleading. You barely get addicted to anything when you use it for a week or two, especially for something that's acute and you're in a monitored setting, which was, of course, the case here. So not only that, though, that's not the only problem I have with the study, but the other problem I have with the study is that they're using one product, which, okay, great, but that doesn't represent the reality of the situation. Go to any online store or brick and mortar store or head shop. What are you going to find? You're going to find 100 different products, and they're all going to say, different things on the label, and they're probably all going to have different things in the bottle than what it says on the label. So that right there is sort of the big argument against it. Certainly that would be something I would be concerned about as a consumer, because, this stuff comes from all over the world. It's not regulated. How do you know what their production and manufacturing, strategies are, and what type of heavy metals are getting put into it or other adulterants? You just don't know. We do know, they've looked at, just even here in Texas, right? They looked at several of the labels, and then they took the medication to the lab and they actually measured it, and the doses were wildly off than what was on the label. It might say 2 grams on the label, and it was like 16 grams in reality. So that's a big deal. And, I think that's definitely a benefit of going through the more traditional routes, let's say going through a physician and pharmacy, and, with much greater likelihood that you're getting what it is that you think you're getting. So that's another problem. And then, of course, Mitraleaf, which is a product of MP Pharma. MP Pharma was what actually funded this study. So, again, I would say a very weak study to support the safety of Kratom in general. And if this is the largest study we have, it's an industry-sponsored study that basically looks at 100 patients that don't match any of the actual patients that would use this in real life. Again, it's not to say Kratom is unsafe, but it's not to say that it is safe. And that's just what we're dealing with. We're dealing with very low research confirmation on this. Part of that reason, and that's what led to Kratom not being approved by the FDA, really for any medical condition. And again, they're thinking that this is going to lead to overdose and death and all these things. Again, on one side, you're going to have proponents of Kratom that say, well, there's no evidence against it, which is true. But on the other hand, you're going to say, well, there's no evidence that it's safe, which is true. So, I think until we have further evidence on that, That's where the challenge. That's where the challenge is. That's where the rub is. I think it's interesting too with the introduction of 7-OH, right? So you can make the argument logically, let's say, that the botanical version of kratom, which includes all the different alkaloids in their natural concentrations, and that's probably how that's been used for thousands of years, is probably at least safer than the 7-OH version. The 7-OH version takes out the most potent alkaloid and then ramps up that dose. And, people have been doing this for the last 100 years. Like marijuana nowadays is not the same marijuana of the hippie era, right? Heroin pretty much, I don't know. Do you guys even see heroin on the streets anymore? Don't let yourself go in the comments. I don't see heroin anymore. It used to be a thing maybe a decade ago, 20 years ago, but it's all fentanyl now. So the drugs keep getting stronger, more potent, stronger, more potent. Now even carfentanil is starting to replace fentanyl, which is, like 100 times stronger. So that's sort of always been the way of the land. And unfortunately, what happens when that happens is it sort of blows up the whole thing. Well, it's like, okay, well, if we have kratom and it's, in its natural leaf form and it's been used forever and we don't really have any data that it's, harming people, it's easy for the governing bodies to look the other way. And then you pull something really potent out of it that is comparable or even stronger than morphine. Now we're getting the eyes looked upon it, right? So there's a couple industry groups out there. You might call them advocacy groups. There's the American Kratom Association, which is referred to as the AKA, let's call them. And then there's the Holistic Alternative Recovery Trust, also known as HART. So we'll call them AKA and HART. AKA is very pro the natural leaf kratom products. Okay. And that's what they're out there promoting. HART, on the other hand, is very pro 7-OH. And so not only do we have like the federal government sort of riling up some distension and the media riling up some controversy, but now we have the grassroots organizations who are battling over kratom as well. The AKA, again, they want, and the reason why they're all battling is because this is a very lucrative business. Everything that exists under the sun, just follow the money. There's a monetary reason why something is happening the way that it's happening. Okay. And kratom is no exception. One of the public voices for AKA, who is very pro the botanical version of kratom, came out and said, these 7-OH products are not traditional kratom. They are being engineered, concentrated, and marketed in ways that create risks that are not associated with natural kratom leaf. Okay, makes sense. I'm on board with that. Yes, it's not traditional kratom. It's a very potent ingredient that they are dosing at much higher doses. Well, HART comes back and says, because they're very pro 7-OH, there's like, no, 7-OH is not a synthetic substance or a novel additive. Also true. It is a natural occurring alkaloid found in the kratom leaf itself. Calling it anything else misrepresents the science. Okay. So again, they're trying to protect their own business, essentially, because the natural kratom argument, the natural kratom people, they see 7-OH coming in much more powerful, which will draw all their business to that. And, and so they're like, no, we need to get the states to outlaw 7-OH. We need to get the FDA to outlaw and the DEA to put it as a Schedule 1. That's where AKA is coming against 7-OH. But again, HART is saying, no, 7-OH is natural. Yes, it might be a little more potent, but let's be honest, it's not exactly an opioid, which is true. Yes, and they're basically likening it again to it's just like a coffee tree. It's just like chocolate. It's just like coffee. It produces opioid-like effects. But come on, where's the evidence to suggest that people are toppling over from this left and right? It's just not there, which is true. So, at least on a grand scale, there's always case reports and things of this nature, but usually that doesn't ever make its way to the main stage. So, you have these professional grassroots advocacy groups, essentially, who are basically destroying each other, trying to protect themselves, destroying each other, and the consumers are watching both of this, and then that sort of drives up the headlines in the media, right? And then that further pushes back the consumers. And then the FDA and the DEA, they can't even get aligned on this. Now, the FDA, of course, as we talked about in the beginning, is very anti-kratom products. In fact, the FDA wants the DEA to schedule 7-OH as a Schedule 1, making it illegal. That's what the FDA wants the DEA to do, but the DEA won't do that. They haven't stepped up on this or commented on this, at least to my knowledge, with regard to this. So you have the DEA and the FDA sort of at odds, and then you have the grassroots advocacy groups at odds, and then the patients are left just kind of scratching their heads, seeing any type of commercial that comes across their Instagram or driving past a store that says Kratom sold here. Well, what is that? And this is, of course, where people sort of get in trouble. Now, the FDA is they are promoting research, of course, into Kratom. They want to see if it's something that can be therapeutic and all of that. But really, where's that going to go? I mean, honestly. So this is sort of where my interpretation on this all comes down to. Okay. Would I ever recommend Kratom? No, I can't. I can't recommend it. I'm a physician. I have an obligation to practice evidence-based medicine, and there's simply no evidence to support or arguably go against on some significant level the use of Kratom. As a consumer, would I use it? Also, no. Mainly because, again, it's unregulated. It is, it's not transparent with regard to how it's manufactured, where it's manufactured, the actual dose that's in the labeled bottle. You can't trust that. And so for all of those reasons, as a consumer, I would not be interested in that. But again, I am not a typical consumer. I'm not in chronic pain, so it's hard for me to make decisions for somebody that, let's say, may not have good access to physicians who can give you proper treatment for your symptoms, right? So I definitely have a respect for that. But at the very least, there should be some informed consent, maybe some education on the matter. But no, I cannot officially recommend that by any stretch. What's interesting, again, okay, so smoking kills 480,000 people a year, right? Smoking, 480,000 people a year. Legal, by the way. Certainly not the big media news hype that Kratom or even opioids has, and smoking kills way more than both of those. Alcohol kills 178,000 people per year, right? So combined, I mean, we're looking at 750,000 people smoking and alcohol, both legal. And here we are debating Kratom, which has also been used for thousands of years, and we don't really have any evidence to speak of whether it's safe or unsafe. There's theoretical risk, of course, but nothing, on paper. So why is this the case? I mean, I'm sure you all have your reasons, and you can put it into the chat or put it into the comments if you're watching this after the fact. But it's all about money. I mean, let's be honest. Okay, so let's say, the FDA, they're like, well, let's fund some studies and, maybe we find something new and novel. And then, of course, they patent it. And then they say, okay, we're going to outlaw all this nonsense at the head shops. And we're going to make this one medication legal because we can control its manufacturing. And that's good, of course. But, of course, it's going to be expensive. So, okay, that's fine, too. That could be a route where we go with this, or because the fact of the matter is it's being banned pretty much everywhere. I don't know how many states have banned it completely. Like 8 states maybe have banned it, and there's more legislation that's being proposed. right? The FDA is trying to get the DEA to make it illegal, at least the 7-OH version. So the momentum and the discussion is going towards banning Kratom altogether, right? So, okay. So they're either going to come out with a new expensive drug that mimics the use of Kratom, but then I ask myself, well, why would they do that? Because we already have opioids. Oh, but opioids are mostly generic. So if they can make something that is more expensive, that is not an opioid, but it acts like an opioid, okay, maybe they'll do that too. But I mean, think of the big money behind smoking, the big money behind alcohol, and then of course the big money behind the chemotherapy industry, right? And the pharmacology, the big pharma that goes along with treating all of the smokers and the alcoholics. I mean, there's no reason for anybody to ban those things. And I'm not even saying they should. And I'm not even saying they should ban Kratom. But the fact of the reality is that's where they're going. So it's just interesting, very controversial topic, no doubt. If you are thinking about using Kratom, all I would encourage you to do is definitely, if you're on an opioid, I would strongly advise against it, just because it can have an additive effect. If you're on an opioid, if you're on benzo or other sedating medication, if you have liver disease or you have a tendency for seizures, let's see what else. I mean, any real health condition, I would advise against it, because the risk tolerance may not be worth it. Definitely talk to your doctor about it. Like I said, more patients are talking to their doctors about it already. Part of why I'm doing this show is to sort of remove the stigma behind Kratom, or even the stigma behind talking about it with your doctor. I know being a patient in today's pain management world has sort of become like, you're on probation and you have to go, meet with your parole officer once a month, pee in a cup and make sure you're not a deviant criminal, right? So yeah, there's a lot of fear and anxiety that's surrounding that. But yeah, I would say, why bet on Kratom if you have better options? If you have better options, why bet on Kratom? Again, it doesn't seem like it's going to be very effective in most cases. And yeah, it's probably not going to do much damage in most cases, but again, we don't have the studies to really support that. So really, can I even say that? Probably not. Now I have seen people that have become addicted to it. So, there is that, but yeah, what do you guys think? Kratom, yay, nay, maybe so. I know many of you don't like the government getting involved on that whole thing. I am more of a libertarian myself when it comes to this, but at the very least, we want to promote education, insight, informed consent, let's call it that, and making sure that, again, you are making the best decision you can for yourself. And that's what we're trying to do here, individualized care, right? So there you go. Let's get into the chat, everybody. Wow, good to see you all again tonight. I'm going to scroll back up here. You guys have been awake tonight. I love it. I love it. Okay, Keith, you're in Sherman tonight. Cool. Thanks for tuning in. Hello, Sandy McCann. Good evening to you. Yes, Keith says women are impacted worse, but the bias against them is the worst as well. I've heard kind of differing stories. What you tell me, if you're a woman and you've experienced bias against your pain syndrome, was your provider a male or a female? I wonder, because I've heard some interesting stories on both sides of that. But yes, generally, I would agree with that statement. It's unfortunate. And what's cool about this study that Jamie sent me is we're getting now more into mainstream understanding the physiology, why women experience perhaps more pain than men. And the more that becomes mainstream, I think the more, because doctors like to intellectualize everything. So if we can intellectualize it and understand some physiologic mechanism, then that can help take away some of the bias. That is true Kevin,
Yes, sir.
so this already happened with high blood pressure. There are certain blood pressure medications that work better for black people than they do for white people.
I've heard of that.
And of course, that has nothing to do with the skin color, but it's the physiology in the kidney.
Mm-hmm.
And so if we can understand that and, not treat everybody the same, this is why we take proper histories and do exams and all of that. The same thing can happen with pain too. So that's the hope anyway.
I was listening to the part that you said about Kratom being labeled as not fit for human consumption.
Yeah, they'll see that on there. Yeah.
That same label is on M&Ms now.
No kidding.
Mm-hmm.
I haven't noticed.
Mm-hmm.
Wow.
Mm-hmm.
Okay.
On candy.
Well, we're going to get into a whole nother level of conspiracy talk here, so I'm going to pull it back. But yes. Oh, man, I like M&Ms. I like the peanut M&Ms.
I think it was the specific peanut ones that I saw them on.
No. I don't identify as human anymore. Yes. So, yeah, some of you maybe not have heard of Kratom. Again, that's probably the third population. You may not have heard it. Certainly, pain doctors are not recommending it on mass. But again, it's like, why? We have much better stuff, safer stuff, proven stuff to use.
You see at the bottom with Erica?
Let's see. Erica, I had worse with female providers. Yeah, interesting. I don't know. Do women always look out for women? I don't know.
I'm not going to get political.
I'm not going to get in there,
put
but I've heard that
Kamala
more
in
often.
office.
That's all I'm saying. I've heard that more often.
Right.
I don't know. I'm just a dude. I don't have an opinion in that matter. But Erica, she says, my stepmom is going through bladder cancer right now. I'm sorry to hear that. She's been going through it for 6 months. Absolutely no pain medication since it started. It's infuriating. Wow. That's horrible. I'm sorry to hear that. Yeah. Cancer is like the one thing that everybody should feel comfortable with prescribing opioids very liberally for. So that's unusual that you might be going through that. Hopefully you find somebody that can bend an ear. Keith says, oh, hi, Robin. You said hello, everyone. Keith says, yeah, tell Rhodes about getting it light. Seems my oxy strength varies every month with them. Zero quality control. Oh, interesting. So even the oxy strength varies. Oh, I was going to go back. So that study about the interleukin 10 and all of this, right? So the monocytes and the production of interleukin 10 seem to be related to testosterone, which is why men make more of it than women. Well, we know in patients who take long-term opioids, let's say, that there's a dump in testosterone. And it's sort of a catch-22 because you need testosterone for the opioid receptors to function. And this is a common cycle that we understand. So this is why, if you're maintained on long-term opioid therapy, if you're not checking your testosterone, you should maybe every 6 months or every year, whenever you're having symptoms, I suppose, and make sure that you have adequate levels of testosterone because you may not be developing opioid tolerance. You may just be, or your pain just may not be getting worse. You may have just a testosterone deficiency, and instead of increasing the opioid, maybe all you need to do is supplement your testosterone, and bada bing, bada boom, you're in good shape. Now, it makes me wonder if that has anything to do also with the production of monocytes and interleukin 10. Definitely something worth looking into. But yes, my point is that this is all very good news for the women, and certainly as we go into this month of fibromyalgia awareness that affects 90% women, the more that we can put a physiologic mechanism to the situation, I think the less stigma and bias there will be, and hopefully the better treatment. Yeah, wow. I'm just reading all the responses to Erica's plight here. That's crazy. Anytime the government gets involved, no one on the outside will prosper. I don't think it's a conspiracy theory to think that those in government will serve those in government before they serve the people. I mean, they'll tell you they're serving you, but, It's for the good of the public. Studies show female docs treat female patients worse. The Girl Who Cried Pain is a great study on it. Okay, thanks for the reference, Keith. I'll have to check in on that. See, I wasn't imagining it. Yeah. Robin says opioids strength differs often. I was told it was the binders, wondering if that's true. Yeah, I don't know. I mean, I have heard very commonly there's differences between different generic forms. One common example that seems to keep coming up is buprenorphine. So like the brand Suboxone versus the generic buprenorphine, and then there's a few different versions of the generic, and maybe they have different colors or different shapes, and patients can really tell which one works and which one doesn't, even though the milligram is the same. So yeah, I mean, I'm sure that's true with probably most medications on some level, especially when you're going from generic to the brand. The brand has a certain recipe that's, protected. The generic just has the active ingredient, and they try to deliver that to your system any way they can. So yeah, I'm sure there's going to be some variability between manufacturers there. But from a safety perspective, the variability, I think, is negligible in most cases. When you're looking at things like Kratom, the variability is astounding. I mean, 10-fold, 20-fold. And if you're naive to this stuff, that can make a big difference in the clinical outcome. So that's the concern I would have. It's kind of like coffee. Anybody get Starbucks drip coffee and then get like drip coffee from literally anywhere else? It is night and day difference. At least that's my experience. I get palpitations with Starbucks, and then everywhere else is, sorry, Starbucks. I don't know. You have strong coffee, I guess. That's a good thing, right? It's very strong. I don't get that same with other brands.
I don't get coffee, but I've been told once or twice I got drip.
Oh, God.
For anyone in the comment that knows what that means.
I don't know, and I don't want to know.
Fashion sense.
Oh, okay. All right, cool. Yeah, you dress nice, Kevin. Thank you.
Why, thank you.
Yeah. Yeah, so, that's the big thing about Kratom. Hopefully that provided some insight. Like I said, it's one of those things that nobody seems to agree on, and it's definitely not something anybody should promote. I'm going to just put that out there. Should it be on the market as an option? Well, I'm a libertarian, so as long as you're educated, you know the risks involved, man, it's your life. And if you're dealing with severe chronic pain and you can't get your hands on anything else, I mean, that's your decision, of course. But as a physician, there's no possible way I can recommend it. There's there's almost literally no evidence to support its efficacy or its safety. And because of that, it's just not something that we can recommend. But on that note, hopefully this was helpful. If you have more questions or comments or concerns, leave them in the comment section. Don't forget to log out and hit a thumbs up on this video. Next week will be Fibromyalgia Week. We're going to get into it. The history, where we were, where we're going, and we'll keep on talking. Until then, you guys take care. It's been a pleasure. See you next time.